Good afternoon, everyone. Welcome to our pop quiz webinar on Incident to Denials and How to Pass. My name is Ashley Dakota, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who's going to be helping out with the chat. This webinar is part 2 in our 2-part Back to School series on Incident to Services. Yesterday, Leanne held the Part 1 study hall session, which provided more details on Incident to Services. Now, if you were not able to attend her session yesterday, that recording will be available within the next week or so. First, I have just a few housekeeping items to go over. We will have a recording of this session available in the Training Center on our website. The Training Center is linked here on this slide, and Leanne will be adding a link to the chat. It will be available there for the next 60 to 90 days, barring any technical issues with the recording. And you can actually access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube at work. The recording will also be available on our YouTube channel as long as the information remains relevant and current. So you'll have that there to rewatch, or if maybe you have someone in your organization that was not able to attend today and wants to watch the recording. Also in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download if you would like to have the presentation to follow along or take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any questions in the chat. If we don't have time for live chat questions or have more questions than time allows for, please don't worry. I will put together a follow-up document that will include answers to all questions that we were not able to get to, and I'll send that out to all attendees. I will be answering those questions that were pre-submitted with registration throughout our presentation today. Lastly, for this slide, we would appreciate you taking some time to provide feedback on our education. Towards the end of the presentation, you will be provided with a couple different ways to take our survey. And Leanne and I would really love to see your feedback on how we've structured this series into 2 sessions. This is our disclaimer slide, and the information given today is as up-to-date and accurate as we can make it. Now, as many of you may know, Medicare rules do change often. We will respond to questions today, though, based on the information provided, but CMS rules determine final coverage. The most current information can always be found on the CMS website, which we have linked for you on this slide. Lastly here, CMS prohibits recording of this presentation for profit-making purposes, so if you are recording or taking screenshots, we do ask that you stop. We are recording this presentation ourselves, and again, we'll have the recording available on our Encore page in the Training Center of our website within the next week or so. And again, that will also be available on our YouTube channel. Because we will be using some CPT codes today, I do have just a few quick disclaimers to share before we get started. On this screen, we have the CPT copyright notice, which indicates that Medicare does not own the CPT codes or their descriptions. Those are owned by the American Medical Association, or AMA. This is a copyright notice for the American Hospital Association. And this disclaimer states that the American Hospital Association is not responsible for, nor were they involved in the preparation of this material or the information that we provide today. Here we have the acronyms that we'll be using today, and I've gathered these here all in one place so you have this for reference, and some of you might be familiar with these, but I did include these as we may have some attending who are a little bit newer to billing Medicare and maybe not as familiar with these acronyms. Again, if you've not already downloaded the presentation, it is still available in the Training Center on our website, and you'll find that under Live Events. So please feel free to download that so you have this acronym slide as a reference. All right, for our agenda. We're going to start off by doing a brief recap from Leanne's Part 1 Study Hall webinar yesterday, where she gave a more comprehensive overview of Incident 2 guidelines and documentation requirements. Again, if you were not able to attend that session, we encourage you to look out for the encore recording on our website or again on our YouTube channel once that becomes available. Next, we will do a review of the top denials and rejections for Incident 2 services. Then we have a question and answer activity planned. Lastly, after that Q&A activity, we will use any time remaining to take live questions through the chat. Also, I wanted to mention that I have included some resources in this presentation, and I'm going to go out to show you a couple of those. These might be resources that you saw or heard about yesterday if you attended Leanne's study hall session, but we really want to make sure you know where these are for today's activity. So let's get started. We'll start out with a quick review of Leanne's Part 1 study hall session. First, Incident 2 services must be an integral, although incidental part of the billing practitioner's services. So it's still an essential part of the billing practitioner's plan of care, but it does not stand alone. And this means that while those non-physician practitioners or ancillary staff may provide these services under the Incident 2 guidelines, the billing practitioner must maintain their involvement in that plan of care. Incident 2 services are those that are commonly furnished in a physician's office without charge, meaning they would be services typically included in the physician's charge. The billing practitioner must provide direct supervision. Now, this does not mean that they need to be there in the room, but they must be immediately available should they need to step in and provide assistance. Those providing the Incident 2 services must have an employment relationship with the billing practitioner. For example, they might be an employee, leased employee, or an independent contractor. The billing practitioner must develop the plan of care. And this means that Incident 2 services do not apply for new patients. The billing practitioner would provide the initial service and develop the plan of care. Incident 2 services would then be provided under the billing practitioner's guidance using that plan of care. The billing practitioner must maintain their involvement, though, in that patient's care. And CMS has not established a frequency that they must see the patient. So this would really be your business decision to determine what's best for your patients and for your practice. Here we have our top denials for Incident 2 services. We did have a pre-submitted question asking about the #1 denial for behavioral health providers related to Incident 2. And the information that we're addressing for this series is not specific to behavioral health. Those requirements are a little bit different. We do have a video, though, on our YouTube channel titled Part B, Mental Health Incident 2, and I encourage you to take a look at that for information that's a little more specific to behavioral health. So our top denial was for services by a chiropractor not covered. And chiropractors are not able to receive payment from Medicare for evaluation and management services, and that would include Incident 2 services. So chiropractors will receive this type of denial if billing for Incident 2 services. A close second on our list was payment included in another service received the same day. For this type of denial, you'll want to look at the NCCI procedure to procedure or PTP edits, and I'm actually going to go out to the CMS website and show you what those look like. So I've gone out to the CMS NCCI webpage, and I've also asked Leanne to place a link in the chat in case you want to save that or follow along. And the first page I'm going to point out here is right here under NCCI implementation. This gives an explanation of PTP edits. And the purpose of PTP edits is to prevent improper payments by making sure that Medicare is not paying for services that should be bundled or should not be reported together. There's also this booklet linked here in this paragraph on how to use the tools on this page, and I really do encourage you to look at that. The tools are listed over here on the top left of this page, and the tool that we're going to focus on is this last one, which is the Medicare NCCI Procedure to Procedure Edits. So once you click on that link, what we're looking for here, if I scroll down just a little bit, there we go, it's under Practitioner PTP Edits. And these links might seem like a lot to take in at first. I know it was for me when I first saw this page, but that booklet that I mentioned will make them much easier to understand. So a little overview on these. Each of these links are titled based on the codes that are included within the attachment, meaning it gives a range of codes. So the first codes listed in the hyperlink title are the first codes listed in the columns within the file that we're going to open. So let me show you what I mean by that. For this example, I'm going to be opening this last one because I know that my code begins with the number 9 and it falls within this range given here. Before I click on this link, I want you to make notes of these, or make note of these two codes here, 62370 and 0213T. Those are going to make a lot more sense once I open this file. So when you click on this link, it will ask you to accept the terms. I'll go ahead and do that. This is running a little, there we go. It's running a little slow. And then it will ask you to download the zip file. Now I've already done that in preparation for the webinar because it can sometimes take a minute. But once that zip file downloads, I'll open that up here for you to see. You'll see a text document and an Excel file, and they contain the same information, but I do find the Excel file much easier to work with. So I've opened that Excel file. Now, if you took note of those codes in the hyperlink title, you'll notice that they're the first codes listed here in column 1 and then in column 2. The other two codes that were in that range in the hyperlink title represent the last codes in column 1 and column 2. The same thing would apply for the other 3 practitioner PTP edit files on that page. So hopefully that helps you in understanding how to determine which of these to open. So to demonstrate why you might receive this type of denial, which again was payment included in another service received the same day, I'm going to first look at what other service was done that day. So let's say, for example, you had a hospital discharge service that day, or code 99238, for example. I find the easiest way to do this is to apply filters. So what I'm going to do is I'm going to select this top row, and I'm going to go over here to sort and filter, and then click filter. And this is going to allow me to narrow down this list to my specific situation. So I'm going to click the down arrow now on the column 1 filter. And I'm going to deselect the select all button. And that can sometimes take a minute because this file is so large. And then I'm going to find my code 99238 by doing a search and click OK. So what this gives me is a list where the code on the left in column 1 indicates the payable code, and the codes in column 2 are included in that or bundled into that column 1 code. So now let's filter column 2. We're going to look for 99211 for our incident 2 service. And I'm going to do the same thing. I'm going to deselect, select all. and then search for that code. So since we found that it is listed in column 2, that means that it is included in our other service in column 1, meaning 99238 in this particular example. Now there's one more thing I want to show you here to help you with these denials, hopefully. In column F, you'll notice a 0 under modifier right here. 0 means a modifier is not allowed for a column 2 code. If column F were to have a 1, that would indicate that an NCCI modifier is allowed for your column 2 code. For example, you might have modifier 24 for a service done during a post-op period, or modifier 25 to describe a significant and separately identifiable service. If you look back at the NCCI page where we started, there is a link you'll find on the left side of the page to an NCCI FAQ library, and that has some information on NCCI modifiers that might also be helpful with these type of denials. With that being one of our top denials, I really wanted to share that with you to hopefully help you avoid those in the future, but there really is a lot to NCCI edits, more than we have time to go over today. So if you're looking for more information, we do have several NCCI edit videos on our YouTube channel. So let's head back to our list of denials. And next we have duplicate charges, which might happen if payment was already made to you for that incident to service for that beneficiary on that date of service. And if you believe your claim denied duplicate in error, you can submit an appeal. Next on our list, we have claims denied while the beneficiary is in a period of managed care. And this would happen when they're enrolled in a Medicare Advantage plan. So make sure to check eligibility, which is something that you can do through our secure portal if you're signed up to use that. And if the beneficiary has a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare does not process those claims. The last denial on our list is Medicare does not pay for this service. And an example of when this denial might happen would be billing for a vaccine. You would not bill this separately as an incident to service. Vaccines are one of those things that have their own benefit category and rules specific to that category and do not fall under the incident to guidelines. So you would not bill the vaccine and 99211 for incident 2 services. It would just be the vaccine. Otherwise, you'll receive this type of denial. All right, now for our top rejections for incident 2 services. Our first rejection is for rendering physician number invalid or missing. For this, it might say denied on the reason code for this one, but this is actually a rejected claim. Also, on your remittance advice, the reason code actually says to submit a new claim, which is exactly what you would do here. Double check that you've included the physician's NPI and that it's the correct NPI, and then resubmit your claim. Our second rejection for incident 2 was claim lacks information needed for adjudication, and we see this one a lot. Something in these cases is missing from your claim. And you'll look at the other reason codes on your remittance advice, and these will provide you a bit more information. But this could be any of the items that are required for that claim to process, such as the patient's date of birth or your place of service, for example. So you'll want to double check your claim form and make sure that all of the required elements are included, and then resubmit your claim. Our next rejection is for no submitted charges billed. The claim will not be able to process without including your charges into either line 24F on the paper claim form or to the electronic equivalent segment. Leaving this field blank or even with $0 will cause your claim to reject, in which case you would just add in your submitted charge and then resubmit your claim. Next, we have incomplete or invalid information for other insurance. So if your claim is rejecting this way, you might want to check item 11 on your 1500 claim form, or again, the electronic equivalent. The claims processing manual in chapter 26 tells us that this is a required field. So you must include other insurance primary to Medicare in this field. But if there's no insurance primary to Medicare, you would still need to enter the word none. Leaving that field blank will cause your claim to reject. Last on our list of incident to rejections is invalid or incorrect diagnosis. You must have at least one ICD-10 diagnosis code listed on your claim. Make sure that this is included in item 21 on your 1500 paper claim form or the electronic equivalent, and double check that you've included a valid diagnosis code. Also, you do not want to include the decimal points in your ICD-10 codes, as the decimal point is assumed. So I did include this slide here as a reference to kind of help summarize what we just talked about for incident to denials and rejections. For your rejections, you're going to fix the error and then resubmit the claim. Keep in mind that for rejections, the claim was not able to fully process, meaning a claim determination was not yet made and the claim does not have appeal rights. Those must be corrected and resubmitted. Now for denials, your next step will really depend on the type of denial you receive. Your remittance advice will be your best source to determine what's next. So it might indicate you need to resubmit your claim, in which case you can correct the error and then resubmit. In some cases, you may be able to correct a minor error through a clerical error reopening using our SecureNet Access portal. For example, if you needed to add, change, or delete certain modifiers, or maybe make a correction to your place of service. And then you may have denials that will require you to appeal if you disagree with the claim determination. And in those cases, your remittance advice would include remark code MA01, which indicates that you have appeal rights. I did include a link on this slide with more information on how to appeal a claim. While this page is not specific to Incident to services, it could certainly be useful for your Medicare appeals, including for your Incident to denials. All right. Next up, we have our Q&A activity. And I added this picture in here just for fun with our back to school theme. That's actually my son you see here on his first day back to school last year. Anyway, for our Q&A activity, we've planned this activity to test your knowledge. On each slide, we're going to be launching a poll, and we do invite everyone to participate if you can. And please don't be afraid to take a guess if you don't know the answer. For each question, we'll give everyone a few moments to submit your answer, and then I'm going to talk about the correct answer. Also, there are a few websites that you may want to reference for this activity, and I've asked Leanne to place links for those in the chat, so you'll have those handy in case you need them. All right, for our first question, we like to start out a little bit on the easier side to give everyone a chance to get accustomed to the polling feature in WebEx. So this question is, Incident to services are provided as an integral, although incidental part of the physician or non-physician practitioner's professional service during diagnosis and treatment. True or false?
And Ashley, I'm just letting you know, I'm going to need to ask you to try and release that poll. For some reason, it's not letting me send that out.
All right, let me pull that up real quick.
Thank you for your patience, all. Sometimes technology has a mind of its own.
Yeah, let's see here. There we go. Hopefully everyone can see that one now.
We can. Thank you, Ashley.
Great, no problem. And those answers are coming in pretty quick. I think everyone gets the gist for this one. Awesome. Love to see everyone participate. All right, the answers are slowing down. So most of you got that one right. The answer to this one is true. And this definition comes directly from the CMS Incident to Services page, which is the first of the links that Leanne added to the chat for this activity. All right, and moving on. Next, we have another true or false question. For E&M services furnished incident to a physician's service, not as part of a physician's service, the physician bills 99211, true or false? Leanne, it did let you launch it for this one, didn't it?
It did.
Okay, great. Sounds good, thanks. All right, we've got lots of answers coming in. It looks like we're kind of split down the middle on this one. All right, so the answer to this one is true. This one is a statement directly from the Claims Processing Manual, Chapter 12. And what this means is 99211 is one of your E&M codes that does not require the presence of a physician. So for services provided by your ancillary staff, only 99211 can be submitted. We had a pre-submitted question that asked about a nurse visit 99211 documentation guidelines. And Leanne went over the documentation guidelines yesterday, but let's do a quick recap of that. So your documentation would need to identify who provided the service, the billing practitioner's availability, meaning they're immediately available to assist. The documentation would also include the plan of care from the billing practitioner and then evidence of their continued involvement in that treatment plan. Another question asked for suggestions on how to perform an internal audit. I would say to make sure that your documentation is clear on these things. Make sure it shows who provided the service, that the supervising physician was immediately available, their plan of care, their continued involvement, all of those things to meet the incident to requirements. Another pre-submitted question was, what are the most common causes of denial during audits of incident to services? One of the most common things we see for incident to services is that documentation does not support it. An example of this is that the documentation does not show the availability of the supervising physician. So you want to make sure that it's clear to a reviewer that the physician was immediately available, meaning available in a way that they could immediately step in to take over or to provide assistance with that patient should the situation call for it. All right, next. Who of the following may provide services incident to a physician? And you'll select all that apply on this one. Is it non-physician practitioners, auxiliary personnel, the patient's sister, or another physician? Oh, we are getting so much participation in that. Everyone's getting their answers in. Those are slowing down, it looks like. All right. So the answer to this one is non-physician practitioners, or NPPs, and auxiliary personnel. So non-physician practitioners may have services provided incident to them, meaning under their supervision where they would bill for the service. But they are also able to provide services incident to an MD or DO. Keep in mind, though, that this would be following the MD or DO's plan of care. If the non-physician practitioner changes the plan of care, the service would no longer be incident to, and it would be billed by that NPP. And you'll hear us say that a lot. I know Leanne mentioned it yesterday, but this is just a really common error that we see for incident to. For auxiliary personnel, this is defined in the Benefit Policy Manual, Chapter 15, in Section 60.1. And what the Benefit Policy Manual tells us is that auxiliary staff may include any individual who's acting under the supervision of a physician as long as there's an employment relationship. So this might be, for example, an employee or an independent contractor of the physician. Notice the last answer here, another physician. This was not one of our correct answers. We've been asked if physicians can provide services incident to another physician, and the answer to that is no. There would really be no benefit to that as far as payment is concerned. You would just bill that under the physician who provided the service. One pre-submitted question was, what portion of the visit by the physician lets him bill the E&M? And for this question, it would depend if this is for incident to or for split shared services. For incident to, the service would be provided by someone other than the billing practitioner under the physician's direct supervision and following their plan of care. Now, if this question is regarding split shared services, which do not apply in an office setting, Leanne and I are doing a series next week on this, but for that, the billing practitioner for a split shared service would be the one who performed the substantive portion of the visit. All right, our next question is, in which of the following places of service do incident to guidelines not apply? And you'll select all that apply here. Is it place of service 22 for on-campus outpatient hospital, 21 for inpatient hospital, 31 for SNF, or place of service 11 for office? I'll give you just another moment. We've still got some answers coming in. All right, it looks like they've slowed down. The answer to this one is our first three options, which are 22, 21, and 31. Leanne talked yesterday about which places of service are eligible for incident to services, which included 11 for office, 32 for nursing facilities, and 12 for the patient's home, only in specific circumstances that we'll talk about later. The places of service that are ineligible are those institutional settings, including outpatient hospital, inpatient hospital, and SNFs. One pre-submitted question asked, are there two different types of incident to, place of service 11 and place of service 19 and 22? And the answer to that is that incident to services are, again, not allowed in institutional settings. So place of service 19 and 22 are not applicable for incident to. Now, as far as a different type of incident to, I wonder if you might be asking about split shared services, which are allowed in facility settings where incident to is prohibited. And again, we're not going to go into detail on that today, but Leanne and I do have that series next week. All right, next up, who is eligible to bill for incident to services? Select all that apply. And our options are MDs and DOs, nurse practitioners, physician assistants, and clinical nurse specialist. Wow, it looks like a lot of you are getting this one right. Okay, so the answer to this one is all of them. Your physicians, meaning MDs and DOs, can bill, and nurse practitioners, physician assistants, and clinical nurse specialists are considered non-physician practitioners who can also bill for Incident to services. One important thing to keep in mind for the billing practitioner is that they must remain involved in the patient's care. So the billing practitioner would see the patient initially and develop a plan of care. Incident to services may be provided following that plan of care and under the direct supervision of the billing practitioner, so long as they continue to be involved in that patient's care. And again, CMS does not require any particular frequency, just that the billing practitioner does provide subsequent services at a frequency that would reflect their active participation in and management of that patient's care. Next up, which of these are true for Incident to services? Select all that apply. Must it represent an expense? Does the billing practitioner need to be present in the room? Does Incident to require direct supervision? And may Incident to services be performed by auxiliary personnel? All right, great job on that one, everyone. All but the second option are correct. So let's talk a little bit about each of these. First, Incident to services must represent an expense to the billing practitioner. Remember we talked about that employment relationship? That employment relationship is required because it represents an expense to the billing practitioner. Or another example is for drugs covered under the Incident to provision. The drug would be administered either by the physician or by auxiliary personnel under the physician's supervision, and the drug must represent an expense to the physician. So if it were a drug that the patient purchased and brought in, that would not meet this criteria. The next one on the list was not one of our correct answers. So the billing practitioner must be present in the room is not a correct statement. The benefit policy manual tells us that direct supervision in an office setting does not require presence in the same room, but they must be present in the office suite and immediately available to provide assistance. And that ties into the third option here. Incident to services do require direct supervision. The last one here, we've covered that incident to services may be performed by auxiliary personnel, but again, under the direct supervision of the billing practitioner following their plan of care. Sorry, I had a little hiccup on the slides there. All right, our next question, here on slide 20. Which of the following may act as auxiliary personnel under the direct supervision of the billing physician? Select all that apply. Is it an employee, non-physician practitioner, another physician within the same group, or leased employee? All right. All of these are correct except for another physician within the same group. Auxiliary staff can include any individual acting under the supervision of a physician as long as there's that employment relationship. So this could include an employee, leased employee, a contracted employee. Non-physician practitioners are able to provide incident to services as auxiliary personnel as long as they're following the billing practitioner's plan of care. If the non-physician practitioner changes or is not following that plan of care, the service would not be incident to. The next question is, which of the following best represents the type of supervision required for Incident to services? Does it require availability to provide immediate assistance? Direct supervision? Is it not required for Incident to services? And is it only required for care management services? All right, the answer here is the first two. The billing practitioner must provide direct supervision for Incident to services by being available to provide immediate assistance. For the last answer option here, for those who might bill care management services, such as chronic care management, those may be provided on an incident to basis under the general supervision of the billing practitioner. And we're not going to go into detail on care management today, but Leanne and I did a series on chronic care management at the end of August, and the recordings are on our YouTube channel. We had a pre-submitted question asking what type of evidence Medicare requires to prove the billing provider was immediately available. The documentation would need to show that the supervising practitioner was immediately available to assist. There would be no intervening time, so they would be in the same office suite in what we like to call speaking loudly distance. That way, if they need to step in to take over care, they are able to. You have to document the billing practitioner's availability. How you do that is a business decision. CMS and the MACs do not provide a template or standard verbiage on how to do that. How the practitioner is immediately available will be unique to each practice. All right, for this question, which are examples of Incident to services? Select all that apply from these options. Is it nursing staff provided monthly B12 injections? The NPP changes the plan of care? The MD and NPP provide care in the hospital? And auxiliary staff provide service under the MD's plan of care. All right, the first and last options here are correct. First, we have nursing staff providing monthly B12 injections, and this could very well be an example of Incident to services. The key to this, though, is that it is being done under the billing practitioner's plan of care. So, for example, if Dr. Green has determined that Betty beneficiary needs to come back once a month for the next 3 months to receive a B12 injection, that would be Dr. Green's plan of care. So when the nursing staff is doing the B12 injection, when Betty comes back the following month, they are following that plan of care. The next choice here, we have situations where the non-physician practitioner changes the plan of care, which means the service is no longer Incident to. And this is why it's so important that your non-physician practitioners are enrolled with Medicare. So if we stick with Dr. Green's plan for Betty beneficiary to have monthly B12 shots, which are being administered by nurse practitioner Phoebe, but let's say Betty comes in for her B12 shot this month and tells Nurse Phoebe about her runny nose, scratchy throat, and ear pain. Well, Nurse Phoebe then provides treatment for a sinus infection, and the service is no longer Incident to. The next option here is a situation where the MD and non-physician practitioner provide care in the hospital. And that would not be an Incident to service because Incident to does not apply in the facility. And then the last option here is a perfect example of Incident to services where the auxiliary staff are providing services under the MD's plan of care. For our next two questions, one moment. There we go. Sorry, I'm having another little technical glitch. For the next two questions, we're going to look at scenarios. For this scenario, nurse practitioner Rachel provides service under Dr. Geller's plan of care for diabetes. During the visit with Nurse Rachel, the patient mentions they also have a rash on their elbow, and Nurse Rachel provides treatment beyond Dr. Geller's plan of care. Which of these answers are true? Would it be billed as incident 2? Did the plan of care change? Would it be billed under Nurse Rachel? Or should the service not be billed at all? And the correct answer for this is the middle two. The plan of care changed for that visit because Nurse Rachel, is treating the new problem, the rash on the elbow. The service would not be billed as incident 2 under Dr. Geller. It would be billed under Nurse Rachel. So really in any situation where you have a non-physician practitioner, like Nurse Rachel in this scenario, who's providing incident 2 services, if the patient brings up a new problem, the physician has not determined a new plan of care for the new problem, the service would be billed by the non-physician practitioner. Another situation could be if the non-physician practitioner is seeing the patient under the physician's plan of care, but the patient mentions side effects from a medication. The non-physician practitioner changes the medication, which changes the plan of care, and the service would be billed under that non-physician practitioner. All right, the next scenario is when nurse practitioner Phoebe has been providing incident 2 services under Dr. Green's plan of care, but Dr. Green has now retired, and Betty beneficiary now only sees nurse Phoebe. Which of these statements are true? Is nurse practitioner Phoebe now the billing practitioner? Is it still billed under Dr. Green? Does Betty need to see a new doctor? And is the service no longer incident 2? All right, sorry about that. I had a little tickle in my throat. So the first and the last options are correct for this one. We're going to move through this one pretty quickly because I still have a few more things I wanted to show you. This question is about modifiers. Which modifier is required to identify incident 2 services? We have FS, 57, 25, or is a modifier not needed to identify incident 2 services? All right, 100% got that one right. Modifiers not needed to identify incident 2 services. I did ask Leanne to put a few references in the chat for that, but for time's sake, we're not going to go into any more detail on modifiers today. All right, this question is, incident 2 services may not be billed to Medicare for which of the following? Is it established patient with a new problem? Established patient with a plan of care and no new problems, new patients, or homebound patients? You'll select all that apply for that one. All right, the answer here is the first and third options. So let's take a quick minute to talk about each of these. The first one, established patients with a new problem would not be following an existing plan of care, so incident 2 would not apply. The second is really what you're looking for with incident 2 services. You have an established patient with an established plan of care developed by the billing practitioner. The service is provided incident 2 following that plan of care, and no new problems are addressed. The third option here for new patients, Incident 2 does not apply for new patients. The last one I want to talk about for a minute. Incident 2 services may be provided in the home if all of the Incident 2 requirements are met, including direct supervision, meaning the supervising physician would be physically present in the home. But Incident 2 services may be provided for homebound patients without the presence of the supervising physician if certain criteria are met. And I'm going to go out now to the Benefit Policy Manual to show you where you can find that information. So what you see here is a resource that I have mentioned a few times already. Again, this is the Benefit Policy Manual, Chapter 15. And this one gives you quite a bit of information on Incident 2 services. But what I want to look at right now as it relates to this question is Section 60.4. There we go. Now, all of Section 60 provides information on Incident 2 services. This section, 60.4, gives us the requirements for Incident 2 services done in the home for homebound patients. And the first thing I want to point out here is what I have highlighted, which tells us that direct supervision is not applicable for Incident 2 services for homebound patients. But what does that mean for Incident 2 services done in the home? Well, you can see just below that paragraph, we have criteria 1 through 5, all of which must be met for Incident 2 services done in the home without presence of the supervising physician. Now, I'm not going to read all of these, but I do want to point out the key requirements and differences for Incident 2 services provided for homebound patients in the home. First, they must be homebound and meet the definition of homebound, which we'll look at in just a minute. For number 2, there is the requirement of general supervision rather than direct. So the physician does not need to be physically present in the home if the requirements are met. Next, the service must represent an expense, which we talked about earlier as a requirement for all Incident 2 services. And the fourth criteria is that the service must be reasonable and necessary. And then this last criteria is really important to make note of. Services that can be provided by a local home health agency are not eligible to be provided Incident 2. So your documentation must show that no home health agency is available in the area, or that the home health agency that is there tells you they're not able to provide the service. So Incident 2 services for homebound patients are really going to be in those medically unserved areas where home health is just not an option. Just below criteria 5, you'll see a list of services that these requirements apply to, meaning services where direct supervision is not required for homebound patients. All right, one last thing in this manual. I know we're getting tight on time. What does CMS mean by homebound? And I'm going to scroll down just a little more to the bottom of page 68, the very bottom of page 68, and the top of page 69. Here, CMS tells us that homebound means both criteria 1 and 2 must be met. Criteria 1 is that due to the patient's condition, they require the use of supportive devices like a walker or wheelchair, or the assistance of another person in order to leave their home. Or the second option to meet criteria 1 is that they have a condition for which leaving their home is medically contraindicated. For example, maybe they have an immune system that is so compromised that leaving the home is very dangerous, or maybe a mental health disorder where they're afraid to leave their home. Criteria 2 here has 2 requirements, both of which must be met. First, there must exist a normal inability to leave their home, and leaving the home must require a considerable and taxing effort. And I know that was a super quick overview as far as for homebound patients and incident to in the home, but I really do encourage you to take a look at that manual if you want to read a little more on that. So back to our presentation, we have one last question. Which of the following are applicable for incident to services provided in the home without the physician? Does it require direct supervision? Can it be provided in addition to services from a home health agency? Does it require the normal inability to leave home? And does leaving home require considerable and taxing effort? All right, the last two answers here are correct. The first might be a little bit tricky. Incident to services in the home do not require direct supervision, but only for patients who meet that homebound criteria we looked at. Only general supervision is required if they meet that criteria. The next option here would not be correct because one of the requirements for incident to services in the home without the practitioner is that if it can be furnished by a local home health agency, it would not be covered as incident to. And then our last two here are correct. With that said, that wraps up our Q&A activity. We do have a resource slide here for your reference. So hopefully you have downloaded the presentation and you can reference those. Unfortunately, we are getting to the top of the hour, so we will not have time to take any live questions, but I will check in and see if there are any questions that we were not able to answer, and I'll make sure that answers are sent out to everyone that was in attendance. So just a few things to wrap up. Please stick with us for just another minute or two. In a few minutes, you will receive an email to thank you for attending. And you don't want to delete this one without reading it. The email contains your certificate of achievement, and it will look like what you see here on your screen. Has your name, contact hours, and if you need to turn it in for credit towards continuing education units. Make sure you stay on the lookout for that. If you did not receive the email, a few things might have happened. You might want to check your spam or junk folder. Make sure to add Messenger at webex.com to your safe sender list so that any future messages will show up. Also, if you joined by phone only, you would not have received this email, as there's not a way for us to capture your email systematically from our attendance record. No need to worry though. If you did join by phone, you are able to email us with the phone number you joined with, and Leanne will be adding that email address into the chat in just a minute. If you do think of any additional questions, you have 7 days from today to submit those, and you'll send them to the education mailbox, and make sure to include pop quiz incident to denials in the subject line so that they make sure those emails come to me. Keep in mind that I'm not able to access any claims history, so you will want to contact customer service for any claims related questions. All right, lastly, please do take a few minutes if you can to complete the survey. Tell us what you liked, what we can do better, and suggest topics for future education. Again, let Leanne and I know what you think about the two-part series. We're really looking forward to your feedback. You can use the link in the chat to take that survey, or when you exit today, you will be prompted to go to an external site, and that external site is the CMS Qualtrics page. You'll see a prompt that will look like the picture here that we've shown you with the little yellow triangle. And we included this image so that you know it's safe, it's not malware, anything like that. And this slide we've included, I'm not going to read this to you, but we do make changes based on the survey feedback. So again, please take that survey if you have just a couple minutes to provide some feedback. All right, and I am sorry we went over just a little bit, but we really appreciate everyone coming today. We appreciate your participation. We do look forward to your survey comments, and we hope to see you again for future events. You may now disconnect.